It's an honor to be here today and to moderate this closing panel. It's 3:30 at the end of an intense day, so give yourself some clarity, get ready. We're gonna be focused. We're in the unique position of having three very, very smart and accomplished folks on our topic, which is high utilizers and their relationship to supportive housing. I'm not sure we'll get there, but in particular, these folks are going to talk through their experience in three different jurisdictions in some ways. We're going to have a view from California, a view from Chicago, and then Liz Misa is going to talk a little bit about the state's vision and what is happening in New York State and obviously in New York City. So we're going to have three, in effect, distinct presentations. We will hold the Q&A and my Q&A and then your Q&A until after they've finished these presentations. I'll introduce them one at a time right before they start. But I will try to reserve at least 15 minutes at the end for you all to think of your zingers. And please make sure that your question is a question and not your feelings on everything on the topic, because what we're all really here to do is listen to these guys give us their insight, and I'm sure you all are as smart as a whip, but let's try and focus it on these guys, okay? So let me first start by introducing everybody one at a time, and because these guys have bios that are the ones that we would all crave, I'm going to make sure that I don't get them wrong. 1 second. Actually took some notes. Okay, so to my immediate left is Josh Bamberger, who has been practicing family medicine with people living in poverty since 1989 and has been working for the San Francisco Department of Public Health, caring for people living with homelessness since 1991. During his time with the Department for Public Health, Dr. Bamberger coordinated all medical and behavioral health services at the Health Department's supportive housing programs, which grew from one building in 1999 to 43 in how much time, Josh?
16 years.
16 years, so that's a fairly substantial growth. In 2006, he helped establish the Housing and Urban Health Clinic, the first integrated health clinic designed to serve people in supportive housing. From August 2012 to January 13, he was special advisor to the executive director of the United States Interagency Council on Homelessness, the federal government's homeless policy agenda, and presently he is the lead local evaluator in San Francisco for the Social Innovation Fund supported randomized trial of housing targeted homelessness with high utilizers. In addition, Dr. Bamberger is the chief medical consultant for Mercy Housing, assisting with policy to bridge the gap between housing and healthcare. So let's give a warm New York welcome to Dr. Bamberger.
Thank you very much, and I'll try to get my New York cred, as I did go to New York Medical College, lived on 86th and 1st, and then down here at 33rd and Park, I think. So I spent some time here, did my time in New York. It's really a pleasure to be here, and thank you very much to Shinny for inviting me. As a homeless healthcare provider, I don't do much good unless I house people. All the metrics that CMS expects me to deliver around hemoglobin A1Cs and colonoscopy rates and all the other preventative services that I'm expected to do to be able to meet the metrics don't help homeless people without the cofactor of housing. So we are in a really critical time where we have to convince the medical system, and New York State is really on the vanguard of this, that investing healthcare dollars in housing is not just the morally right thing to do, which we all know, and every animal on earth knows, that to be able to have a place to rest your head is the thing you do at the end of every day. We all know that, but to convince the healthcare system that's actually a good investment, and then to get them to pay for it is where we're at today. So I'm just going to briefly give you an overview of places in the country that are figuring this out, that have overcome CMS's arbitrary line as to where they're going to spend their money, and have found local ways to invest in housing as a healthcare treatment. So the first way is using just new money that comes into local environments. So in San Francisco, we had the opportunity of a first dot-com bubble. We're now in our second. In the first bubble is when we started the Housing and Urban Health section and the Direct Access to Housing program in San Francisco, which launched our first building, as Eric said, in '99, and now we're up to 43. And then Salt Lake City is also another really interesting example where they have really ended homelessness for all, both chronically homeless and for veterans. And there it's not just a local investment, but it's also a large philanthropy investment, where the Mormon Church, the Church of Latter-day Saints, has invested a lot of their tithed money in developing new buildings and providing services, and have done so as a community. They are us, is what Salt Lake City says, and they have ended homelessness. And then the third example is new monies that come from the federal government through the HUD-BASH program to create this healthcare treatment that the healthcare sector prioritizes using HUD vouchers to move the needle on homelessness for veterans. So that's new money strategy. It's tough to go to your politician and say, give us new money. We want to do something good. Really, it's hard to make hay on that. Another way is what you've done here in New York is you have new allocations based on expected future savings. So Liz will talk a lot more about this, but this is really a fantastic opportunity where the healthcare system finds expected savings and then uses a ledger transfer over to the housing sector so that the healthcare sector can prioritize using their skills on how to prioritize healthcare dollars, but then the housing sector can figure out how to do what you do so well, which is to build housing and to provide rental subsidies, what the healthcare sector is not good at. That doesn't mean that they shouldn't pay for it. And then lastly is what's going on in Los Angeles, which is where there's new monies that have come in through ACA to the healthcare sector, but what the health director did just with a stroke of genius is say, we are a healthcare delivery agency, and we have been providing free care to people who haven't been insured with our employees, doctors and nurses who are employed by the health department. We are now going to get a significant revenue, $200-300 of new money for those services. We cannot use that new money for housing, but it can free up the general fund that was being used for those services. And now we can capture that in a lockbox and have a pool, a local housing subsidy pool that can be used for rental subsidies and services. Fantastic. San Francisco, our version was called Direct Access to Housing, is called Direct Access to Housing. We started in '99, it's local money, and we initially only did master leased SRO, which are really great in terms of speed, not so great in terms of quality, right? And we're never in alignment in mission between the owners of the property and the services we're delivering. So they can go the owners can go retire to Hawaii, and they'll get a check every month, signed Edmund Lee, who's the mayor of San Francisco these days, and we then get to decide who goes into those buildings. After we proved that we could do this work and not have the buildings burned down and not have major problems with the neighborhood, we were able to get the affordable housing folks to also play in the game, and we were able to then have tax credit and other traditional fundings where we would then pay for some of the services through the health department. This is just a quick slide that shows our growth since '99, where half of the buildings are now new. And now this is switching gears just really quickly to talk about what mistakes we made in San Francisco that I hope you don't replicate here in New York. And I hope that they don't replicate the mistakes in Los Angeles, where the health director in San Francisco is now the health director. So this is a slide that just comes from the work I was doing at USICH, which shows some communities which were on track and have successfully achieved ending homelessness or achieving, close to zero for veterans. And what these 5 quite diverse communities, Hennepin County, which is Minneapolis, Lexington, Kentucky, Tacoma, Washington, Fort Worth, Texas, and Birmingham, Alabama did, was they targeted their HUD-VASH vouchers towards the highest users of the healthcare system who have medical problems. They were able to coordinate with a single list, as we heard about in New Orleans earlier, if anyone went to that talk, had a single list. They knew who their homeless veterans were, and they found out who was sick, and they made sure those are the people who got the vouchers first. Not ever, but first. Now, why does that work? Because it's not just getting the sick people off the streets and freeing up healthcare dollars to do other things. It's also getting the case managers who've been working so hard on the streets with a caseload of 1 to 15. Now they can up their caseload to 1 to 30 or 1 to 50 because the sick people are now housed. And now they can leverage that already available resources to serve other homeless people and really move the needle. So housing the sick people first is critical. This is San Francisco's numbers, not so good, right? Flat. And what have we done? Well, we've spent a huge amount of public dollars, $130 million annually for a city government, more than any government per capita in the United States, and we have not moved the needle because we did not target. As a city, we were stuck. We had these incredibly high housing prices, and the only way to house someone is to use the health department's brand of housing, because there was no other game in town that was doing the job as effectively. So this is a cautionary tale. All right, I'm going to switch gears once again, just to talk about another research that we're doing, and then I'm going to end with our randomized trials results for the first year. This is an opportunity we had in San Francisco, which I think has a lot of relevance in New York, is we were the subject of an Olmstead suit. The target, the plaintiffs, whatever, I don't know what, no, what's the opposite of plaintiffs? Huh? Yeah, those guys, we're the defendants in the Olmstead suit. And a class action suit was brought by the tenants, residents, patients of Laguna Honda Hospital, which is the large public health hospital in San Francisco. And rather than go to trial, we settled that we would house 100 people a year for 5 years to give them an alternative to the institutional living, which violated the Olmstead decision of the Americans with Disabilities Act. And this was great. We didn't have to go to trial. Everyone wanted to get them housed, and it was just another way to free up local funds. It made the city set aside $3 million a year to provide housing for these folks. Half of them were housed in our housing, the direct access to housing. Other half were housed in scattered site. Now, the only reason I wanted to show you this is about the issue of quality and supportive housing, which is really powerful to me. This very simple graph shows that the people who came from Laguna Honda Hospital through the Olmstead decision, the Olmstead case, some of them were placed in SRO housing, and some of them were placed in new housing that was mixed income. The people who were placed in SRO housing are represented by the folks on the far right of that slide. And their mortality rate was 83%. It's not good, right? And then the folks on the far left, which was a mixed senior-only new building, same neighborhood, same resources, same case management, having a nurse on site, they only had a 40% only, which is still very high, but still a 40% mortality rate. So I just want to share this slide because of all the talks I've heard, I haven't heard about the quality of the housing impacting mortality. This is an important point. Not only does quality reduce healthcare costs more, higher quality reduces the cost of healthcare more than lower quality housing, but it also reduces mortality rate. And now I'm just going to end with our latest study, which is a really exciting and perhaps unethical study, to do a randomized trial of permanent supportive housing, where we started with a universe of 30,000 people who were enrolled in the public managed care program called the San Francisco Health Plan. We mined their database until we could assure ourselves that we had 180 people who were both high users of the healthcare system and homeless. Then we went out and found those 180 people and actually verified if they were truly homeless, whether on the streets or in shelters, not doubling up, not in institutions. And we found 50 people who were in the treatment arm, actually 54, and 56 people who were in the control arm. And we're following them for 5 years. Of the 54 people who we identified who were in the treatment arm, 52 of them accepted housing in one supportive housing facility. I'm going to give you the results on their health care utilization of these two arms. The most important slide is not the one you might have thought was coming next. This is the most important slide because this shows the health care utilization of the comparison group, not the treatment group. The reason why this is the most important slide is because I've done this study many times, and every time I do this study, people say it's not valid because you didn't have a comparison group. If you had left the people alone, they would have gotten cheaper anyway. Wrong. In San Francisco, in an environment where there is no other alternative to our supportive housing, if you leave people on the streets or just randomly assign them to the comparison group, their healthcare costs increase from one year to the next. So this is the 50 people who were not in housing. Their healthcare costs as a group went up from $1.5 million to $1.6 million. And this is the people who moved into housing, right? 1.8 million as a group, down to 517,000, about $27,000 per person per year. And I've looked at the second-year data. It is sustained. You know, it's amazing that we don't have investors investing in supportive housing like we do Hep C treatment, because the opportunity for return on investment is extraordinary. So in conclusion, I just want to make a few pretty straightforward points. One is that if you want to have the biggest bang for the buck, now housing is a right, not a privilege. So deciding who gets housing based on value is unethical, slippery slope, I think. Nonetheless, if you want to have the biggest bang for the buck, you have to target the people who are sickest. Unfortunately, if you expect the agencies that are doing the housing to figure out who's the sickest, it increases the burden on them that may be slowing down the whole system. Secondly, better housing provides better outcomes. If you want to spend $1 million on a psychiatrist for the next 4 years, that's cool. But I'd rather you spend that on balconies and light and windows and color schemes and all the other things that you guys do so much better than I will ever do, because that will improve people's health care better than the psychiatrist. No offense to my psychiatrist friends. Prioritizing housing towards high users of the healthcare system and people exiting nursing home frees up other resources. So it's not just that you're reducing the cost, but you already have these fantastic case managers out there working incredibly hard. And if they don't have to work as hard for the sickest of the sick, they can also attend to more people and improve their outcomes for the whole population. And lastly, we are just dependent on HUD to give us all our housing resources. The big money out there is the healthcare system. And if we just keep depending on HUD and the politicians in Washington to somehow free up or allocate money that as HUD should be, I would much prefer HUD to get the money, but they're just not going to get it. So how are we going to position ourselves now? If HUD is not going to do it, if the government is not going to fund HUD, what is our role as advocates for housing? What's our role in terms of our relationship with CMS? Do we become, enemies? Or do we continue to say, oh, everything is fine, tra-la-la-la-la, it's okay that you've set this line that you're not going to use Medicaid dollars for rental subsidies. Is that okay? Where do we need to position ourselves? And what's the right strategy? Our federal partners say, don't scare the medical people by saying that housing is health care. But on the other hand, we're not getting HUD funded. So where are we going to position ourselves? And we better get a strategy, because there are a lot smarter people, a lot more funded people out there who are trying to get that federal dollar for other things. So I'll end there, and I look forward to questions afterwards. Thank you.
Thank you, Josh. I think your conclusion could have been the cost slide, but that's another thing. Okay, so while they're setting up the slides, let me introduce Art. Art Bendixen is Executive Director of the Center for Housing and Health, which promotes the coordination, research, evaluation, and policy development of housing and health programs that serve the chronically ill, homeless, and unstably housed in the city of Chicago. The center is a supporting agency of the AIDS Foundation of Chicago. In 1996, Art was a founding member of the Chicago Partnership to End Homelessness and a board member and officer for 7 years from 1999 to 2006. In 2007, the partnership merged with the Chicago Continuum of Care Office to become the Chicago Alliance to End Homelessness. He was also a founding member of the Chicago Continuum of Care Program Office and continues to serve on their council. It's great that Shinny thought to include best practices and models from around the country, and Josh and Art are shining examples. And let's welcome Art.
Thank you, Eric, and good afternoon. Buenas tardes. I am Latino, even though a number of my Latino colleagues tell me I don't look Latino, but you may pick up my accent here and there. So let me first of all thank Shinny for this opportunity to be here. We know that New Yorkers consider themselves the first city. Well, you have somebody here from the second city of Chicago. And I can tell you, you need to be very proud of what New York State and New York City do for supportive housing. You guys are the envy of the rest of the country, certainly the envy, at least of, I know, Illinois and a number of other states. What your Medicaid office is doing, what your New York programs are doing, many of us wish we could do. And we know that it's not enough, but at least you guys have shown how important supportive housing is to the community. And finally, let me say as an introduction here that I'm glad I'm following my colleague Josh, Dr. Josh Bamberger. I have followed his work for many years, so it's nice to follow him here. And he certainly represents not only incredible research, but the perspective of a doctor. I'm coming more from the perspective of a supportive housing provider. I've been doing this for 21 years in Chicago, and the last few I have been involved working with supportive housing providers throughout the metropolitan area. So that's where I'm coming from. I'll also use some research, but more than anything, talk about the supportive housing side of things. So quickly, I'm going to tell you about a collaboration we've built, the value of a supportive housing unit, demand being greater than supply, healthcare system payers, which is what we're really looking for. In some ways, you guys have started doing that already. Then targeting PSH units, which Josh began to talk about so well. How to pay for these PSH units, especially if you're working with managed care organizations, which is what we're trying to do, and then some future challenges, all in 8 minutes or less. We have went out and got new dresses to look more attractive, but to tell you the truth, we didn't have to pay much money because a lot of the research done around the country and also in Chicago has shown the tremendous value of a supportive housing unit. And so in Chicago and in Illinois, we have to deal with the managed care organizations that are administering Medicaid. We went from a totally fee-for-service system where medical providers, behavioral health providers, built Medicaid directly to now 9 insurance companies, Aetna, Blue Cross Blue Shield, and the others are handling Medicaid. And so we have began dating the MCOs by saying to them, okay, you need us, we look a lot more attractive. So we organized ourselves as a collaborative back in November. We represent 80% of all the supportive housing units in Chicago and Cook County, and about 70% of all the providers. And the whole idea is to negotiate from a power of value and strength. So again, we don't have to spend too much money on this, but I think it's really important that we as supportive housing providers really understand this. Value is different from cost. Simple example. Buy a brand new car. Costs you $20,000. You drive out of the parking lot of the store, what happens? The value. You all of a sudden lost about $3,000. So the value is different from the cost. And the reason our units are so valuable, and I have to tell you this, is because we do basically what the Affordable Care Act is asking for. We increase access to care, we improve certainly the quality of your care, and we reduce unnecessary costs. And again, we have tremendous data for that around the country. San Francisco has done it, we have done it in Chicago, the Veterans Administration have done it. So we have to, I'm talking to you as a supportive housing providers, we don't think of our units as something that we can sell, that's a valuable commodity. It is. And the more we act like that with the healthcare world, the more we'll be able to serve more people that are homeless. Why is this so important? Give you an idea. In Chicago, from 2008 to 2013, the feds were giving us, through HUD homeless dollars, about $2 to $4 million every year through bonus projects. And we were able to create about 300 units of supportive housing every year. Since 2013, we've gone flat funded. No more supportive housing, new supportive housing units in our city. We have about 8,000 units between Chicago and Cook County. We need another 4,000. And now that the healthcare world wants to house people, because if not, they're going to lose money. I was at a session a little earlier where the crowd had a big laugh when somebody said, well, hospitals are not discharging people to the streets, and everybody started making a noise like this. The same thing happens in Chicago, but what's changing is that hospitals are not going to discharge people to the streets, because if they get re-hospitalized, they're not going to get paid for that anymore. Mm-hmm. So they want our units. Demand is there, so how do we get, what Josh said so well, how do we get healthcare payers to pay for at least some of our units. The healthcare payers, of course, are Medicaid, state Medicaid dollars right now, like you do here, what LA County has done. But also we're finding hospitals all of a sudden are very interested in paying, at least for temporary housing now, and we have now a negotiation as a collaborative for them to pay for at least long-term housing, at least for the first couple of years. And then, of course, we are having to deal in Illinois with the managed care organizations. So very briefly, and I know I want to finish soon. This is one of the hospitals that's contracting with us to pay for 25 supportive housing units. Told us that they have identified 48 very high users of Medicaid who are homeless. Not on Medicaid of course, but also their hospital. Look at this one gentleman. In 83 days, he did all this. First of all, spent $70,000 of their money, for which they only got reimbursed $20,000. He had all these ER visits, all these inpatient admissions. Look how many ambulance rides he had, almost one for every other day. This is one of 48 users in the University of Illinois Hospital, which is not a huge hospital in Chicago. Our county hospital probably could do this 10 times more. So they're very interested in our units. I cannot agree more with Josh that we have to, though, as we're doing this, target the right people to go into these units that the healthcare world is going to be paying for. And that's about 20% of the homeless people that are still unhoused, at least in Chicago. One final piece of data. Some of you may be familiar that Medicaid divides people into 10 brackets, 10 deciles, from the highest users to the lowest users. If you pick people from the top 3 deciles, the top 3 brackets, it's about maybe 1 to 2% of the Medicaid users, and you get those identified who are homeless, you will have huge savings. This is from a study we've done, just a small local study followed on a major random control trial that we did in 2009. We housed a number of people from the top 3 deciles. On average, each one was costing Medicaid $76,000 before they got housed. After 18 months of stable housing and good supportive housing, the annual cost went down to $37,000 for a savings of $38,000 per year. When you house people in this category, that's when you're going to get healthcare systems to pay more and more for our units. Finally, let me just say how to pay for these units. That's the biggest challenge in states like Illinois and others because we don't have our Medicaid department paying some. We don't have our county department paying some like in LA. So we have to figure out creative ways to work with the MCOs, the managed care organizations, the Aetna, the Blue Cross Blue Shields to do so. A couple of 2 slides. The LA project that Josh mentioned, they are creating 10,000 new units of supportive housing using the county tax dollars. They have figured out their data. They've done their data well, which, by the way, is so important to do this, that they could actually save $32,000 per person on average for these when they house the high users. The previous slide showed $38,000, so we're about in the same bracket. So these are the top 4 insurance companies in Chicago who are housing homeless people on Medicaid: Blue Cross Blue Shield, Aetna, Allina Care, County Care, and then there's the hospital accountable care organizations. Right now, they're all approaching us. They're all finding us very attractive. They're saying, how can we get people housed? And we say to them, well, unless you contract with us, put them into the coordinated access list. We have a list where they can put people in, and God help them to see when they're going to get housed, because there aren't that many empty housing units available in our homeless system. And so right now, they are willing to negotiate with us, and probably next year, if they invite me again here, I'll have some more specific results. But some of the challenges, and this is the last slide, is healthcare payers basically are questioning, for how many years are we going to have to do this? MCOs, managed care organizations, especially say, we only keep people a year at a time, sometimes a couple of months at a time. So if we give you money for somebody, for Charlie Brown leaves in a year, what do? We're not going to keep giving you money for Charlie. So that's a challenge that we are addressing. What happens when the house person not only leaves, but what if he switches insurance companies? But the last one really is one of the biggest one. we think we have a tremendous value not only in the way we house people, but in the role of our case managers. So the reason we're doing these pilot contracts with the managed care organizations is to show how well our case managers will work with the care coordinators from the MCOs. In Illinois, we don't have health homes yet, so we don't have care coordinators. The care coordinators are in the MCOs. And the MCOs are realizing they don't know how to work with homeless people. And so our case managers are helping them, and these pilots will show that. So that's basically what we're doing, and hopefully we'll continue to learn from you. And if we can help in any way, we're more than happy to. Thank you.
So the way we constructed this panel was that we had two national ringers, and then we have our own ringer. And if you don't know Liz Misa, you should, because she's in the middle of this for New York State, and in my view is doing a spectacular job, and has been a super asset to Robin Hood in helping us think about how to project this issue long term. And let me give you a little bit of Liz's background. Liz was appointed by Governor Cuomo to serve as the Deputy Medicaid Director in the New York State Office of Health Insurance Programs in April of 2012. In that role, Ms. Misa assists with the day-to-day operations of the office, which manages the state's $54 billion Medicaid program and has more than 600 staff. She assists the Medicaid director in implementing the reforms put forward by Governor's Medicaid redesign team and is co-chair of the MRT Affordable Housing Work Group. She's been a leader in developing more supportive housing targeted to high users of Medicaid, and we all have been following that progress. Ms. Misa also co-authored Housing is Healthcare, New York's Boundary Crossing Experiment, that was published in December of 2013's issue of the New England Journal of Medicine. Previously, Liz spent 5 years as governor analyst at Hinman Straub, where she was involved in all aspects of the firm's health and long-term care practice, including advocacy. Liz's background is long and distinguished, but let's welcome Liz for thoughts about New York State's direction.
You want to get out of there? It's yours.
You may just need to go forward. You may need to go forward just one, I think.
I think I figured it out up there last one.
There we go.
Thank you, everyone, and good afternoon. And I'm really, really happy to be here. I always love talking about what we're doing with Medicaid redesign and supportive housing. And when I started with the Department of Health over 3 years ago, I had the great opportunity to work on this project. And as you can see, we've increased our investments every year. So right now, we've invested over $388 million in MRT supportive housing. And what we do is we take the savings that's generated under the Medicaid global spending cap through other initiatives, and we take those savings and we reinvest those into supportive housing. We target high-cost Medicaid users, and we fund 3 major initiatives. We fund the capital construction of new supportive housing units throughout the state. We also fund rental subsidies and service supports, and we also fund operating dollars. In addition, we are really interested in outcomes and measures and research and evaluation in order to demonstrate that supportive housing works, take that data, try to get a federal dollar for all of the state dollars that we've invested in the state of New York to make and to grow the investments that we have. So as I mentioned, the MRT targets high-cost Medicaid users, and everyone wants to know, what does that mean? What's the threshold? What's the definition? We don't use deciles. What we do instead is really target our high-cost Medicaid members based upon health home enrollment and eligibility. Because we know that there's a very small percentage of Medicaid members, about 5% of our Medicaid members generate over half the cost to the program. And so what we're doing is we're trying to target those members. All of those are really eligible for health homes, and what does that mean? That means it's individuals who are on Medicaid who have 2 or more chronic conditions, or they have one single qualifying condition, either HIV or serious mental illness. And what have we done to date? We have, I think, over 20 to 25 programs that we've operated. All have started over the past 3 to 4 years. We serve right now over 9,000 Medicaid members throughout the state. And even though we have not set a strict definition for our high-cost Medicaid members, what we do know is that the data, this is early data, the results are really moving in the right direction. This data is from the end of 2014, and we still need to do some data cleansing, so it should have a big draft watermark on it. But what it is essentially showing is, as our members in the supportive housing program is increasing, that the average cost per member is going down. And this is really one of the things that we're trying to demonstrate through the program. I think everyone in this room knows the value of supportive housing. We know that an individual can't manage their health care without housing. So what we're trying to do is demonstrate that when you move individuals who have chronic conditions into housing, you move them off the street, you put them in supportive housing, it's not only better for the member, but it saves money. And so what we're looking to do is we're looking to take that savings and increase housing throughout the state and save money at the same time to further increase the stock of supportive housing throughout the state. This is just another slide, early, very preliminary results, but what it does show is even though we have not yet enforced a strict definition of what it means to be a high-cost Medicaid member, we know that housing as an intervention does work. It is decreasing inpatient admissions, it's decreasing ER visits, and these are the trends that we want to see. These are the trends that we expect to see. And the good news is that's what we have been seeing to date. Just as a little disclaimer, the data is very, very early in its infancy. We collect data from all of our agency partners. The MRT is really a collaborative effort with OMH, OASIS, OTDA, our AIDS Institute, our Office of Long-Term Care within the department. We also work with HCR to build housing. But what we do know is that as we're collecting the data, we take the data very seriously just to prove the case and to demonstrate that housing as an intervention works, that Medicaid should increase their investments in housing, and how do we do that and reinvest those into housing. So as I mentioned, one of the biggest challenges that we face is how do we target better, how do we establish a strict definition in the MRT program. And I struggle with this every day, as something that happened, I think, 2 or 3 weeks ago. I'm just sitting in my office in Albany, and someone dials the phone, and they say, Liz, there's someone who is at the health department. They just showed up. They're homeless. They want to know how do they access MRT housing. And I said, okay, I'll take the call. So I took the call, and it was this woman, and she said, I'm homeless. I was a victim of 9/11. I have PTSD. Before that experience, I was working, and I had a place to live. And now I don't have a house. I'm disabled. She went to the local DSS. She wasn't in shelter. She was actually in a hotel because she was too disabled for shelter. And she said, I went to apply for MRT housing, and they told me I wasn't eligible because I didn't go into the emergency room enough. And I said, well, what program did you go to? And, she went to a particular provider that was really trying to demonstrate the savings. And they were using a tool, and it said she didn't use ER enough, and so they said she wasn't eligible. So what I did was I just picked up the phone, and I said, she's homeless, she's disabled, that should, and she's on Medicaid, that should be enough to move her into housing, and luckily enough they did. And so that's why every day I say, how do we structure a program that is flexible enough for the people that we serve, but also demonstrates the savings that we want to show. So I would say That's one of the biggest challenges that I face. If you guys have any recommendations, please feel free during the comment period, because I would love to hear your thoughts and ideas on that particular issue. But really, in terms of next steps, what are we doing? We have a lot of data from all of the agencies from our programs that have been up and running for the past 3 or 4 years. We're cleansing the data. What does that mean? It's really a fancy way of saying we want to make sure that the right people are in the right unit and we have the right identifications to illustrate that we're tracking the right people. And salient bookmarks, that's a really fancy way of saying if I wanted to call one of my staff and say, how many people are in supportive housing? How many dollars have we saved? How much has ER use gone down in 6 months? That's really the data that will show us. And then what we're really trying to do is we're really trying to look at trends with each program and population. What's working? What isn't working? How do we change policy moving forward to restructure the program to make sure that as we're really making policy decisions at a state level, we want to make sure it's working at the local level. So that's really our biggest goal with Medicaid redesign. So thank you.
So let's get into the questions, and so start thinking about yours, and I'll suggest a few to start. First, to say to Shinny, if you look at this agenda today, outside of the couple of panels that were sort of the more macro panels about the State of the Union, notice how much of it dealt with health. And so I think, Liz, I'll give you a break for a second. You just went, but starting with Josh, can you talk a little bit about health care for this population? You are a family doctor. You talked, in my view, your conclusion that resonated the most, I think, with this room was the reduction in cost, which presumes that folks were engaged in care, consistently engaged in care, and probably more stable than they were when they were at the $1.6 million price tag, or then when they were at the $500,000 price tag. Can you talk a little bit about the ability of managed care to be able to adapt to these patients, what their challenges are, and what they're doing well, and where there's room for growth? Yeah, please.
So it's really interesting. We're conflating 3 different endpoints, and we need to identify that. So there are 3 different things we're trying to measure to see that we're doing good, right? One is cost, another is mortality, and the third is the number of homeless people on the streets. So as a healthcare provider, and I would hope as a managed care organization, they'd embrace that housing is a healthcare treatment that needs to be invested in to improve that one part of the triple aim, which is improving outcomes. And we use cost as a proxy for that outcome. Now, if we don't target the highest users of the healthcare system, then my hypothesis is we won't move the needle on the number of homeless people on the streets. So it's not just because we reduce the cost, it's because we free up resources that then can be attended to other people and thereby move the needle on homeless numbers. So if you're just trying to treat the person in front of you, of course you house them. If you're trying to reduce the cost, you house the people who are sick. But if you're trying to reduce the number, you actually have to wait to house the person who isn't that sick. Let HUD and the welfare system, as inadequate as it is, prioritize those resources towards those people. But for the person in front of us, we need to prioritize those others. So it's an awful, almost Sophie's choice problem. But we need to be really smart, or else we're going to run out. Even the large amount of money that New York State has set aside is going to run out. Los Angeles County is going to run out of that $300 million. They get it annually, but it's still not enough. They need to continue to show that the government can get smaller and end homelessness. That is a difficult bind, but we can, I really believe we can do this.
Can you just talk a little bit more, though, about this issue about quality of care and the specialization of care for the population we're most concerned of, and what you saw as being sort of the best practice?
Sure. So 75% of every pill that's prescribed in the United States goes down the drain. Do you know that? 1 of 4 pills gets eaten. If you're living on the streets, you don't eat your pills. So it doesn't matter how much you're prescribing. If you can't be someplace to keep your pills safe and have someone, if you need to remind you to take them, you don't get better. So one of the reasons why housing is such a critical piece of the quality equation is because when you're housed, you can often adhere to your medications, and all the billions of dollars that go into the pharmaceutical industry, which they're happy, by the way, to have it go down the toilet, right? They still get to refill those medicines, and they get their money. But it doesn't benefit people unless they take it. So that's, I think, the simplest, just distilled thing about why housing is so important. Besides it, the underlying problem with homelessness is trauma, and the treatment for trauma is safety, right? So those two things together, adherence and safety, I think are critical as to why housing is such a valuable commodity. What did you say? Ask.
Thanks. Art, you talked a lot about the relationship between the housing case management team and care coordination. And I wonder if you could talk a little bit more about specifically where that interface is working well, and from a scaled perspective, what that challenge looks like down the road.
Sure, and especially I'm speaking from something that is beginning in Illinois and in other states. So it's certainly, we have a lot more to learn over the months and years to come. But especially when you're talking about vulnerable homeless people, that especially those who have been housed, but also you could say the same thing for those who are on the streets. Care coordinators, and again, our experience with care coordinators is those done by the MCOs, managed care companies, which is, from what I've been hearing today, your health homes are doing a certain amount of care coordination that's somewhat similar. They're more focused on care coordinating the healthcare teams. The psychiatrist, the social worker, the doctor, the nurse, they're focusing on making sure that there's a good care coordination among them serving the particular individual. Housing case managers have much of a broader stroke approach where they're worried about, is the person going to pay their rent on time? Is the person getting along with the next door neighbor? Is the person taking their meds on a regular basis because they go visit them at home quite a bit? It really, the case manager pays much more attention to the social determinants of health. That is the foundation for what the care coordination is doing. We have found out that often a care coordinator is taking weeks to find somebody. We finally get them to contact the case manager, and the case manager says, hey, you have the wrong address. I know where the person lives. I know when you can call them. And that's just one small example of the way when you get a good care coordinator and a good case manager working together, things begin to happen. Without the foundation of a good housing case manager, care coordinators often cannot do their job. And our Aetnas and the Blue Cross Blue Shields are beginning to realize that for the homeless population. They cannot do telephonic care coordination that's effective with homeless people, or even 100-to-1 or 50-to-1 care coordination. For the highly vulnerable homeless people, we have found 15-to-1 case management ratio is what really makes things happen, improve outcomes, and save a lot of money.
Thanks. Okay, Liz, for the next 5 or 10 minutes, it's just you and me, right? I mean, nobody else is here, so everything you say is just you're telling me privately in my office. You realize that, right? Everybody duck. So I guess the question that I think all of us are curious about is you could help give us some perspective on what growth looks like and how you're projecting out what this trend looks like out of Albany. I think, though, before we start there, can you help us understand how you're keeping score? And what I mean by that is you sort of talked through essentially the capital allocation, the operations allocation, and the rent allocation. When you're comparing those budget lines against what you want to see in terms of progress around Medicaid usage and presumably health outcomes, how are you keeping score in your office? So when you're not fielding the call from the woman who you connected to housing, and bravo, what does the scorecard look like?
So the scorecard changes every year, but essentially how it starts is, as I mentioned, this funding comes from the Medicaid global spending cap. And that cap does grow. It's a rolling 10-year CPI, so we do have room for growth every year within the cap.
Tell everybody what a CPI is.
Consumer Price Index. So I think year to year, the growth was a little under 4%, but when the base is billions of dollars, 4% is a significant increase year to year. But essentially, every investment made under the cap results in a savings under the cap, so it has to be budget neutral. So the investments made in housing for the MRT are possible because there are savings in other areas in the Medicaid program. The goal is really the triple aim: how do you increase access and reduce costs? And so, as you can see, we've increased our funding every year. That's always been the intent behind the Medicaid redesign program, while at the same time demonstrating the cost effectiveness of our investment. And so that cost effectiveness has taken us, a couple years to ramp up because to get the systems ready, to get the data into the system. And right now, as I mentioned, the data cleanse, the data is only good as what's put in. And so this summer, we're going to spend some time making sure that the input is correct. But the real goal is to take the savings through the system and reinvest those to develop more housing. So our goal every year is to increase the investments made. So I can't give you a hard number, but I can say every year our goal is to increase the investments.
And can you talk a little bit about, from the growth perspective, what that's looked like in terms of working with healthcare providers?
What do you mean?
So in terms of when you're thinking about the kind of indicators you're getting back, what's the feedback you're getting from managed care in terms of how they're growing with the state's program?
So right now, we have not had really any conversations with managed care in terms of housing. We are, as an administration, moving almost all of our populations and services into managed care under our Care Management for All model. But what we are doing is tracking the individuals who receive housing through our MRT supportive housing programs. We can tell who's in fee-for-service, who's in a plan. We can tell if they're in a plan, what plan. And then we can see the savings that are generated by individual. And then what we are going to do is go to the plans and to say, this is how much we've saved you in the premium on your healthcare side because of housing as an intervention. And so we haven't had those conversations yet because we don't have the data in that detail, but that's where we're heading.
And Josh talked a little bit about the front door initially in terms of figuring out a way that assessment in the beginning is targeting the housing to the folks that need it the most. Can you help us understand between the state and the city what that direction looks like down the road? And ideally, what would you like to see? Where would you like to see us in a year and a half, 2 years, 3 years?
Well, ideally, I would like to see anyone who needs housing to get housing.
Yeah.
I know that, that's a lofty goal. So what we're trying to do is to figure out how to always increase the resources. Another thing, and I know no one likes this subject, but for folks that maybe need housing, but they don't need supportive housing, how do you successfully move those individuals into affordable housing to increase units for those who need it more? We always have those conversations, and we're going to have additional conversations this summer on how do you do that. But our real goal is to figure out, without setting up the strictest definition, how do we really move everyone who needs housing into housing in the state? And I know that that's a very, very big goal. It's a challenge. We try to figure out how do we get new resources to the table, social impact bonds, what ways can we increase funding? We continue to go to our federal partners to try to get a federal share. On our state-only dollars, that would double the amount of money that we have currently. So we're always brainstorming new ideas, but we're just, we haven't landed on the right answer yet.
Yeah. Josh, in the control that you talked about before, which I think was like a 52-56 or 54-56 split, did any demographic surprise you from an illness perspective, from a demographic perspective, age, anything?
I haven't analyzed the data to that impact. I've really been looking at the cost. So you have to have a big enough pool. But I think it doesn't really matter. And to New York State's what are you going to do? Do you wait for someone to get sick to get better? I mean, that's crazy, right? This woman you described, you send her to the emergency room, break her knee, and now she can get into housing? That's stupid, right? So that's a very defendable position, right? But the person who's really expensive is going to then free up money so that you can house somebody else who doesn't have to break their knee. So when do you do what? I think, and there's a study in Canada, well, it must not be accurate if it's in Canada, but the Chez Soi at Home study was a really fantastic, also randomized trial, 3,500 people. And what they found is that people who were in the top 10% of the healthcare expenditure had a savings of $2.50 for every dollar spent in housing, $2.50 in healthcare costs for every dollar spent in housing. The next 40%, it was about equal. And the last 50%, it cost more in housing than it did reduce in healthcare costs. So again, if what is driving your ability to keep the engine going is continuing to capture healthcare costs, you gotta start with the expensive people. And I would be so happy to hear the story in New York that there's enough political commitment and moral commitment to fund housing so that people who are sick can be housed. That would be so much better than this tiered system. But if you have to do it incrementally, you got to start with the expensive folks.
Please, Art.
And I would just add that having been in the homeless housing world, we welcome in some ways the fact that HUD gave priority to chronically homeless people. But many of us said, hey, how about somebody who's been homeless for 10 months? We got to get them housed too. One of the things that to me we should do for advocacy is HUD doesn't have enough money to house all the homeless. Well, maybe if HUD monies that we have now get focused more on those who are less expensive to the healthcare world, and the healthcare world focuses on those who are expensive to them, maybe we can move forward that way. Everybody needs to get housed. And so let HUD and HHS work together to make sure that the healthcare world pays for those who are affecting their system, and HUD can pay for hopefully a good number of the rest of them.
One of the fun byproducts of having worked at Robinhood is my boss is an ex-reporter for the Times. So we're usually charged with trying to come up with a headline. It seems like there are two big headlines coming out of this panel. One is that if you house people who are high utilizers of Medicaid, you're going to reduce costs and people will be healthier. And the second one is that we've got a real problem when it comes to capital. And how to marry those two, I think, is the pickle. Liz mentioned social impact bonds, but I throw this to all three of you. You have a really nice set of data points to create a propaganda machine, and you have a one game in town HUD funder. I think our governor used to know something about HUD. So what do you think it's going to take on the capital side? Because if we're proving a smart experiment that's both producing outcomes on the health side and reducing costs, that is the recipe you presume to do good and do good again and expand that good. What do you think it's going to take from a creative perspective to be able to figure out the housing side?
Maybe I could just start because my two colleagues can probably expand a lot more on the question, but to me, the Los Angeles project is an excellent example of not just relying on Medicaid. The county health department in LA went from about 30 to 40% insured people to almost 80 to 85 because of Medicaid expansion. They had, all these millions of dollars of new Medicaid money coming in to cover the hospitalizations, emergency room visits that county tax dollars were covering before. So like Josh said very well, all of a sudden you had this freed up county tax dollars. And instead of giving them back to the county to beautify planters and more trees in the county preserves, they decided to use county dollars, hopefully together with Medicaid dollars, to house the homeless. Our counties and our cities, and I think you guys do much better than most of the rest of the country, our counties need to take responsibility for the homeless also, and not just leave it up to the feds or to Medicaid.
Well, I think the housing stock question is a huge question that I'm really glad you brought up. So one of my jobs, it says here, Mercy Housing, is I left my job leading a health clinic for homeless people to focus on working with Mercy Housing, which is an affordable housing developer. And the reason is that we have this new scheme, and scheme is good in housing, I hear. That's a good word, right? It's not like a, okay. Anyway, we have this housing idea where we can acquire sort of rundown hotels and apartment buildings using retail loans, and then wrap the cost of financing that loan into the monthly charge that we're going to charge the Los Angeles Department of Health. And we can get about $1,800 per month per person price tag, which includes all the support services, all the rental subsidy, and financing the loan. Now, that might not work in, you guys who are more familiar with New York City prices, that might not work. But in some of like San Gabriel Valley, San Fernando Valley, down by Long Beach, up in Antelope Valley, Los Angeles County is huge. There's, things to be had. And we can then increase the housing stock and delivering a price point that is the same when they're doing master leasing or even doing some HUD-funded project-based stuff. So that is a really critical piece to the puzzle. And if there's the appetite within the New York State Health Department to be able to have a reasonable price point, and you guys can find ways to roll in the acquisition, renovation, and financing of the loan into a monthly cost, then you can align the way that the New York State Health Department spends its money with the way that you can then increase the housing stock. So I think it's a critical piece that has been a little bit anemic in its ideas. I'm sure there are way better people out there than Mercy Housing to do this, and many of them are in this room, I imagine.
Liz, do you want to make a closing shot here before we let some folks ask some other questions?
Yeah, and I mean, I don't think I'm going to say anything that the rest of the room doesn't know, but especially in the city of New York, land doesn't even exist, right? I mean, we've put money into capital, and all of our buildings, I think, were built in the Bronx, not because that's where all of the need was, but because that's where the land was. And we're running out of it, and I don't have an answer to that, so what do we do? Do we retrofit or take healthcare facilities that are maybe downsizing, move those into supportive housing, create medical villages? I think outside of the city, it's easier because, there is land to create more housing, but the city has I think, unique problems that I unfortunately don't have an answer for today.
Until you keep producing more good data about savings, and then we're going to kind of come up with some. I should have managed the time a little bit better. It's 6 or 7 minutes left. Folks with questions? Yeah. Oh, Steve, hi.
So government subsidized private developers to build housing all the time, and we don't really require them to do much of anything. Hold the data with 421A programs going on right now. We could be putting people into buildings, and the developers, the private developers, don't really want poor people living that close to their wealthy renters. We're talking about rental housing. Condominiums, I can understand, they're trying to sell units, and there's different issues there. But in rental housing, we should have much more access to those units. If they're using any kind of government funding or subsidized mortgages or whatever.
Steve, what do you want them to give you feedback on? Just to say you're right.
You're right.
Private developers are building housing, and they're using government subsidies to build a lot of it. It's happening in Queens, it's happening in Brooklyn, it's happening all over the place. And we're not getting set-asides in those units, even 5% set-asides for the next 100 or 200,000 units that are going to get built. It's going to produce a lot of units. And to expect nonprofits to build us out of this is really unrealistic.
It's a fair point. Do one of you all want to comment on that? Or?
I mean, I certainly understand your point, Steve. I don't know if, HCR, and I don't like to pass the buck, but maybe more, of an expert here to address your specific concerns.
I think there's money to be had. I think there's investment to be made in every sector, the nonprofit and the for-profit sector. I think the way that Art mentioned, you got to make it attractive. So in San Francisco, we first couldn't get the affordable housing people to be interested in housing homeless people because they thought it was going to destroy their building when my patients moved in. And we proved that actually we kind of gentrified the neighborhood compared to many of the other buildings that are going on. So with that as our lead, then I think you can get a lot more people to buy into it. I haven't been in New York for a long time, but there's a lot of buildings that are underutilized. I mean, you got to think sort of the Airbnb world, right? When I go on vacation, if someone rents my house, I get money. There's a lot of vacant room that's not fully house. I really do believe that. And again, I know I'm speaking out of school, but I really do think that there are, rundown Motel 6s that are being red tagged by the local area that can be turned into supportive housing. It isn't that much that we need. 10,000 units in this city of this size is not that out of reach.
Sharon?
Eric had said that there was the problem of capital, but I also think that there is a problem of inadequate rental subsidy for low-income folks. And, so I know that there were some pilot projects through the Medicaid MRT to utilize Medicaid dollars for rental subsidies, which I think is a really important thing, but it's very limited in its scope. And I'm wondering, do you have strategies for financing of rental subsidies that, from a policy perspective, could address this issue? Because sometimes we build the units and we can't get the grants to put them.
Yeah, and I certainly understand and I hear that challenge. I think with our MRT, one of the biggest challenges that we faced was every state agency, or almost every state agency, had a different rental subsidy. It wasn't standardized. I tried to change that with MRT to try to create a standardized process. And if we brought everybody up, the price tag was too high. But I do understand the concerns. We try to set the rental subsidy at the fair market value and rate. But I think especially in the city, I know that there are certain programs or pilots that there are waiting lists and there's a rental subsidy, but the biggest challenge is it's not enough. So we continue to think about ways, how do we address that?
I think this also gets back to the issue of targeting. So if I want to get a patient of mine on an electric wheelchair, right, it costs $25,000. To get that, I have to fill out this really long form, and I hate it, right? But I fill out the form, and then a occupational therapist comes and sees my patient. They decide, do they actually have upper body strength so that they can manage a manual wheelchair? Yes, no. They do this whole thing, and then once the whole assessment is done, then they say, actually, they do need an electric wheelchair, and we then pay for it, right? So if we put our patients through that kind of a process, then we can say, well, actually, we do need to pay that extra rental subsidy, because that's what's going to make this person both well, which is our reason why we get up in the morning, remember? And it's going to save money. So I think, if we're going to do a healthcare intervention, we got to talk the language of a healthcare intervention, and we have to also subject ourselves to the difficult process of giving people the pre-authorization necessary to get the treatment.
Let's take one more, sir.
I was wondering, in terms of case coordinating, comparing a person that's in supportive housing versus a person who's in housing, not part of a larger unit, versus a person who's out on the street. What's the effectiveness of case coordination in those three instances?
Liz, do you have a perspective on that from the state, or do you want to tackle a piece of that? It's a big question.
Yeah, I mean, we are doing, comparisons, or about to launch comparisons with individuals in supportive housing and individuals not in supportive housing. We have a research and, evaluation RFP. Unfortunately, we're in the blackout period, so we can't really talk about it, but those types of research and evaluations will happen.
So almost everyone we've housed in our housing comes with case management, and the case management hasn't moved the needle on cost. When they're housed, then that same case management also moves the needle on cost. And I think we also have to be really careful about the ACT data, which we've all sort of built a lot on. The assertive community treatment data shows that if you provide case management for people with severe and persistent mental illness, then you reduce healthcare costs. Well, that was done in an era when people were hospitalized for psychiatric conditions for longer and easier. And now that it's actually quite difficult to get into the hospital, and when people do get into a psychiatric hospital, they turn around, they're also a lot cheaper. So the side of the ledger where they were expensive before ACT is now not going to be as high, so we're not going to see ACT bang for the buck. So again, it's housing to get the return on investment.
I'm not necessarily one of trying to make things look like Hollywood, but this is the right way to end this conference, and with a real dramatic sort of set of some evidence that suggests why what we do is super important. I think both Art, Josh, and Liz all told that exact same story slightly differently, and I'm glad it was the way to close the conference. So thank you so much for your attention, and a particular thanks to Josh, Art, and Liz.
That was my father right there. That's for sure.
What?
That was my father.
How's your dad?
You guys
Is that good? Okay, good. They were great.
You know,
They were great. That was a good channel.